The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. I'm Tony Urbanek, and we are here again for the next episode of TMD Demystified. I say good morning to all of you because I consistently, routinely make these episodes on Tuesday mornings, put it in my schedule, make sure it's done. When you may be listening to it, this could be midnight in your neck of the woods or your end of the world. So it's good morning, good afternoon, or good day. But to me, it's always going to be morning because that's when I'm brightest, and that's when I find that I'm mentally prepared to do these episodes. Today, I find our episode very interesting. I hope you also. The title of the episode is TMD and Sleep Dentistry. I have a lot to say about that, but I'm going to try to make it concise, certainly within the next 30 minutes. I'm not going to go deeply into sleep dentistry, although I practiced my end of sleep dentistry for, my entire career. We're going to define sleep apnea and snoring, the difference between the two. And we will talk a little bit about what my experience was in sleep dentistry. And for sure, the reason for the episode is how that applies or does not apply to TMD. And in our case, in the dental realm, most of the treatment for in sleep dentistry is done with oral appliances. And that's what the TMD appliance has in common with sleep dentistry. They're both oral appliances, and there's a lot more to say about that. So for those watching, I want to do a brief review of sleep apnea, a little bit just to mention sleep snoring in relation to sleep apnea, because I don't take for granted that you are watching this and have any experience with treating those entities, although there may be some who are expert at treating sleep apnea with oral appliances. In my career, I used an oral appliance for treatment of sleep apnea, which I had many patients referred to me. As an oral maxillofacial surgeon, early in my career, I learned to apply orthognathic surgery to the problem of sleep apnea. It's a big operation. Maxillary mandibular advancement works really well for selected cases that have no other option. And for the last half of my career as an oral maxillofacial surgeon, I used a device. This is just the one I favored. There are many other devices. The EMA device that is very simple to make, simple to use. Patients seem to use it reasonably well. We'll talk about that in a minute. And then we'll talk specifically about the relationship between TMD and sleep apnea and the relationship and the sleep devices and the relationship between those devices, which is very important to understand, which is really the message of this whole episode. So let's just begin with what is sleep apnea. And this is how I describe it have described it to my patients. When a patient came in to see me on referral, almost all of them on referral from pulmonologists, my medical colleagues who found that their patients would not tolerate the CPAP. All right, so what is sleep apnea? This is how I defined it to patients. In the back of your throat, behind the tongue, posterior to the tongue, there is a oropharyngeal airway. In the past, in my career, my ENT colleagues used to do UPPP, which was a uvulopalatoplasty. We basically cored out the entire back of the throat, including the soft palate, the uvula, the tonsils. Very, very painful procedure. It took weeks and weeks and weeks to recover. Unfortunately, and they did that in the early stages of understanding sleep apnea and understanding how it worked and where the obstruction were. It was thought that it was really the soft palate, which it's not. But that procedure was done hundreds of times, many times that I witnessed here in Middle Tennessee, always by the ENT doctors, and it really was not effective in treating sleep apnea. Snoring for sure. You'd had that procedure done, you wouldn't snore, but it didn't fix sleep apnea. But that's just historical. Now we know that the obstruction is behind the tongue, in the oropharyngeal airway behind the tongue. So what happens in sleep apnea, and again, I'm directing this, excuse me if you are expert in this area. This is super simple. This is what I say to the patients. Behind the tongue, there's an airway, and it has a certain width to it. And while you're awake, the muscles are in tension or tone, and they hold their airway open. And when you go to sleep, the muscles relax and the airway collapses. If you are a healthy patient and do not have sleep apnea, the muscles collapse and allow the pharyngeal airway to get narrower and smaller, but still there's enough room for air to go up and down behind the tongue. In sleep apnea patients, the airway is narrower to begin with. And when you go to sleep, the muscles relax and the airway collapses. And until you wake up, you're not going to move any airway up and down. That is called a hypopneic apneic event, AHI. And the metric or the definition of sleep apnea is based on the AHI, apneic hypopneic index, and is defined by whether the number of AHIs are small, medium, or great. Mild sleep apnea is defined as AHIs between 5 and 15 per hour, moderate between 15 and 30 per hour, and severe greater than 30 events per hour. Hypopneic apneic events per hour. And that is how sleep apnea is defined, and that is exactly anatomically, physiologically what happens in sleep apnea, and all this occurs behind the tongue. That is important to remember, behind the tongue. So historically, my pulmonology colleagues were successful in treating sleep apnea well, using a CPAP machine of various kinds. Historically, they were very cumbersome, very loud, very hard to titrate the amount of pressure, basically, but a mask that literally forces air through the obstruction, pushes it apart, and at a certain rate per hour, at a certain pressure, millimeters of pressure, water pressure. And that is how pulmonologists began treating TMD years and years ago with the CPAP machine, and still is, in my estimation, not as a pulmonologist or a researcher in this area, but by just observation as a medical provider, the best solution, which gets the consistent, high quality job done, as getting through the obstruction. The problem with a CPAP, quite frankly, and it hasn't changed, only gotten worse with time, is patients do not like the CPAP. It is uncomfortable, even in the more modern types, which are less obstructive, easier to use. I have no disagreement with any of that. but still, and the machines are much less are less loud. They're not silent, but they do not make a lot of noise like the old machines did. Patients still do not like that. And most recently, over the past few years, before I quit treating patients with obstructive sleep apnea, because I quit 6 months ago, quit doing any kind of procedures or patient contacts other than non-surgical TMD 6 months ago. I quit doing any kind of oral surgery, office oral surgery. As I stated many times, I quit doing hospital major reconstructive cases a few years ago, dropped back to just office procedures, and finally pulled the plug on office procedures 6 years ago, and totally devote my time, my patient time, which is only 1 day a week. My associate handles it the rest of the time, and my time is spent on business development for the Urbanic device and protocol in our business. But the point is that up until 6 months ago, I was treating patients with sleep apnea by using an oral device. I don't know whether you can see that well, but that was the device I used. It's called the Meyerson. There are other devices that are similar in nature, in function. I think all of them are good. This one I liked best because it was simple, it was effective, patients liked it, it was easy to understand and use, and all it does with elastics between the upper piece and the lower piece is pulls the mandible forward. My pulmonology colleagues got to the point a few years ago, I began getting increasing numbers of patients referred to me from pulmonologists, and the message was, we're not even recommending the CPAP anymore because we know we recommend it, the patient buys it, they go through this workup, and then they throw it away and don't use it. We would much rather see them use an oral device that does not have as good a record, a statistical usefulness, although it is very useful. It is significantly improved, and I'll talk about that in a minute by my own experience. But we prefer to send them for an oral appliance because they know they're not going to use the CPAP. And not every pulmonologist feels like that, but I had an increasing number of pulmonologists who sent patients with that message. They'd rather just use the oral appliances because they know they're not going to use the CPAP. And then, of course, the majority of patients would come in after using the CPAP and said, I cannot use this. And I heard that there's an oral device that can help me. All right, with again, my experience, it was pretty broad, and I did hundreds of these intraoral devices, which piece fits over the maxillary teeth, piece fits over the mandibular teeth, not unlike an aligner, with a hook on each side and a large tractive element that pulls the mandible forward. Now, the average need to pull the mandible forward is not that much. I did some investigation on that on my own patients in my own record, and it seems to be about 7 millimeters. If you can pull the mandible, put traction on the mandible and pull it forward 7 millimeters, that seemed to be the ideal degree or size of the traction. Most people would get benefit from that, significant benefit. In my own experience, roughly, without doing an analytical statistical study, because I did not do a study on using an oral device for CPAP, but I can say truthfully that I witnessed probably patients coming back 80% of the time or a little more and say that device helped significantly with my sleep apnea. Now, again, I did not carry this any further. I don't claim to carry it any further. I could have done a lot of studies, but in my private practice, I certainly did not have time or inclination to do that. So the point being that an intraoral device with putting traction on the mandible forward to approximately 7 millimeters does a pretty good job of helping patients with the problem of sleep apnea. All right. We talked about what the metrics are. We didn't talk a lot about the decrease in PO2. That is the degree of oxygen within the blood, which can be measured easily. And just a word about the difference between home studies and polysomnograms. Polysomnograms are done in a lab overnight. They give the best estimation of the degree of sleep apnea. They measure more than just the oxygen level and the number of times the patient quit breathing. That actually, it only measures the time that the patient quit breathing, not overall the time, not how long each. That polysomnogram can measure and does measure the length of each AHI, where home studies do not. Home studies just give a general time frame of how much time overall is spent on decreased breathing, AHIs. Again, I don't claim to be an expert on it, but I do say if you're going to do a study that has any value, go ahead and do the polysomnogram. A home study is just, it doesn't tell you a whole lot other than, yeah, you probably have some degree of sleep apnea. All right, what does all this have to do with TMD? It is very profound. It has a lot to do with TMD. And it is this. Again, in my experience, because I saw many patients with the problem and I see thousands of patients with TMD, I began to see patients who had intraoral devices which put traction on the mandible, pulling it forward, who developed TMD symptoms. Obviously, the majority of patients with sleep apnea are males, although there's an increasing number I found of females filtering into the office. By far, the greatest number is males. We weren't going to talk about TMD any further. It increases with age, it increases with the plasticity of the intraoral tissues and the extraoral tissues, and the size of the neck and the length of the neck. But the point is that there's a definitely relationship between sleep apnea and males. And I began to see many patients come in here who had been in a device either for a short period of time or a long period of time, who began to complain of headaches, earaches, jaw pain, neck pain that they did not have before. And basically, here's how it works. I mean, it's quite simple in concept. You know, a healthy joint which does not create inflammation in the joint, that is not damaged, the condyle will sit nicely and without any kinds of pressure against the meniscus within the glenoid fossa. Centric relation, whatever that centric relation is. And again, I'm not going to spend any time defining the specifics of centric relation, and it can vary between patients. It can vary between a patient over time. It can vary between the health health of the bone or other tissues within the glenoid fossa. But the point is, centric relation is the position that is most comfortable position of the condyle within the glenoid fossa, centric relation. If you're treating this with an intraoral device, you treat it by pulling the mandible forward, ideally 7 millimeters. At that point, you are stressing the tissue and damaging the inside of the joint when that goes on long enough, creating inflammation, and then the inflammation causes the symptoms. That's what we discovered with our device in history and study. And obviously the two are opposed, diametrically opposed in concept and usefulness. The TMD device allows the mandible to go back to centric relation, unloading the joint, allowing the inflammation to go down. An intraoral sleep apnea device pulls the mandible forward out of position, increasing damage within the temporomandibular joint and therefore inflammation within the temporomandibular joint, therefore increasing symptoms. I don't claim that everyone who wears a sleep device will create TMD symptoms. Don't claim that. I don't know what percentage. We have seen boatloads of it, but I can't claim what percentage, but we know it happens. All right, so that's the basic problem as it relates to TMD and sleep dentistry. I think sleep dentistry has a future. I think sleep dentistry should be addressed by the dental community. But the dental community who is doing sleep dentistry using intraoral devices needs to be really well aware. That's the message, that at times you are creating TMD problems and symptoms. And then it's a matter of what do you do about it? What can you do about it? Because they're diametrically opposed devices, diametrically opposed. Both of them work very well, but they're diametrically opposed. All right, and what I worked out and seemed to be somewhat effective was the following. If you tried, you can try and use both devices. Obviously, you have to wear the intraoral sleep apnea device while you're sleeping. That is the time it needs to be most effective. It's also the time that patients are most likely to brux. But the point is that it's a matter of what's more important to that particular patient in the hands of that particular doctor, which is more important to treat, the sleep apnea or the TMD symptoms. And of course, that has everything to do, and that's why I took time to explain the concept of AHI and what it is and how you monitor that metric as to mild, moderate, and severe. And I've talked a lot about TMD and the degree of which those symptoms can literally ruin a patient's life: headache, earache, jaw pain, etc. Won't go through this whole litany again. So the doctor treating, if he runs into experiences and the patient experiences this diametrically opposed problem, it needs to be addressed thoughtfully, carefully, but there's no way, I think, that you could actually do this on an analytical metric basis. It's more what the patient feels, their personal experience, which has to be translated to the provider so that he can kind of talk the patient through this. But in my experience, in my consultations, I would say the following: which set of symptoms bothers you the most? Which is more important to you? Is your sleep apnea severe, or is your TMD symptoms severe? That's the first point, just to make with the patient, because ultimately the patient is going to make this decision. I'm speaking now as if I would speak to a patient, knowing that the patient's going to make the ultimate decision which device or combination of devices, which I'll go over in a moment, they can theoretically use. And again, this whole concept is imperfect, I admit it, but in my mind, it's the best that I could come up with in trying to help these folks. So let's just say, as an example, my sleep apnea is severe. I mean, you got 40 AHIs per hour, and I'm tired all day long, and I caught myself almost going to sleep at the wheel. That's serious. So would the patient prefer, theoretically, to treat their sleep apnea first? Well, that's true. In that patient, that they would say, well, yeah, and this problem of irritation of my jaw joint, every morning I wake up and I have pain, little discomfort. Let's just call it a little bit of pain here in this joint. But once I take the device out, within an hour or two, the pain goes away and doesn't happen until the next morning. Well, in that case, I would say to the patient, first of all, you need to wear your sleep device instead of your TMD device during the night. What I also did in several patients is to tell the patient to, let's just say the opposite. Let's just say they had a sleep study or just a home study, which showed they had mild sleep apnea. But their TMD symptoms have been going on for 20 years, and they wake up every morning with a headache, and they have shoulder pain, and their neck is always tight, and they have ringing in their ears for 10 years. Well, in that case, I would suggest to the patient that they wear the TMD device, quote, the urbanic device, instead of the sleep apnea device. And then on a few patients, what I've recommended, and again, it's balancing out the symptoms and also the thought process of the patient. What's more important to the patient? It's not me. It's not what's important to me. It's what's important to the patient. I have said, on occasion, what you can do is you can wear your sleep device at night while you are sleeping, where the only time it's going to be beneficial, and you can put the TMD device in your mouth and wear it during the day. And you will get some benefit during the day if you're having symptoms, because during the day it's in your mouth and allows the condyle and the mandible to go back to centric relation, alleviating inflammation. So within the joint, you can imagine there's this push and pull up and down of inflammation constantly. And like one device increases inflammation, the other device, let me put that the other way. One device increases the inflammation and the other device decreases inflammation. So again, what was discovered, it's all about inflammation in the joint. The inflammation causes all the TMD symptoms, and it's a balancing act between those two devices as to how to use it. I hope I made this simple, and I hope I made it clear, and I really hope I've been some help to you doctors out there who are in the dental sleep medicine arena. I think it's a good arena for you to work in. I think it's you'd be substantially helpful to a great number of people. Remember, our pulmonology comrades and compatriots in the medical industry are coming more and more to the decision that telling patient to do a CPAP and get a CPAP machine is less and less effective because they just won't use them. I think I've covered all the points that I wanted to make. I don't think I could say it any better. I hate to repeat myself too much, although sometimes repeating is good for emphasis. So for today, I just invite you, if you have any comments on this episode, if you'd like to talk to me, you can reach me at tony@tmjservices.net. Our director of marketing and education can be reached at Naomi, Naomi @tmjservices.net. TMD is a huge problem. Frankly, the statistics, I did look up statistics for sleep apnea. It's claimed that over 40 million Americans suffer from sleep apnea. And we know that at least 45% of females suffer from significant symptoms of TMD, which converts, if you do the math, within the population of the United States, roughly 350 million people, that converts into 76 million females in the United States have TMD symptoms, significant TMD symptoms. So actually TMD is a larger problem than sleep apnea. You can say, well, which one's more important? Well, that is, I've said, more important is a decision with the patient, which is more important to you to treat, which is more of a devastating problem for you. And your doctor, your treating doctor, can help you make the decision, maybe make a suggestion or two, give you the data as to how to think about it, but ultimately the decision is made from the patient, by the patient. But if you'd like to learn more about our company, our device in treating TMD, which is extremely successful, we have our independent research, which has been done through an independent university, qualifying the statistics that I frequently quote. You can contact us at tmj.com. www.tmjservices.com. So for today, we'll wrap it up. I am Tony Urbanic, and this is TMD Demystified. I look forward to speaking with you again. I hope you return on the next Tuesday morning. Have a good week.